Our next journey into what's new in medicine will be in maternal-fetal medicine. We've invited Dr. Paul Whitecar, who's an obstetrician gynecologist specializing in maternal-fetal medicine at McCady Hospital, or the practice of perinatology. He is an adjunct associate professor of maternal-fetal medicine at the University of Utah, board certified in obstetrics and gynecology. Earned a fellowship at the University of North Carolina Hospitals, completed residency at Brooke Army Medical Center, and attended medical school at the Uniformed Services University of Health Sciences. Dr. Whitecar, the time is yours.
Well, thanks so much for inviting me. As I mentioned, I recently moved to the area. I did my training in the military. I grew up in southern Idaho and decided to do something a little bit different and went to West Point for my undergraduate training and then uniformed services after that. So I was basically an indentured servant for the biggest part of my career. I took a job when I retired from the Army at Wake Forest Medical Center, and I thought that I'd spend the rest of my career in North Carolina, but all my kids moved out to Utah and went to school here and never came back. And so I saw the writing on the wall and decided to move back. And so it's a pleasure for me to be back in the area. A few changes coming back from the East Coast, but I enjoyed a great deal. So I thought about this topic quite a bit. There have been so many changes in our specialty, and what I wanted to talk a little bit about was spina bifida and advances in fetal surgery. I think that one of the things that's happened in our specialty that fetal surgery is probably the newest surgical subspecialty, and it's really had a huge impact on what we do in prenatal diagnosis. And so I wanted to talk a little bit about that specifically. See if I can figure this out. I don't have any disclosures. So the objectives of my talk, I wanted to first of all, review the epidemiology, some of the risk factors associated with spina bifida, talk a little bit about prenatal diagnosis, which is our bread and butter, review the rationale for prenatal repairs and different options. The one thing that for spina bifida is open fetal surgery, and we're now starting to do that here in Utah. And then fetoscopic repair of spina bifida and some of the risks and benefits. So just taking a step back, spina bifida is really a subset of open neural tube defects. And broad picture, there are really two types. There's the closed or spina bifida occulta or open spina bifida aperta. Spina bifida occulta is a defect in the posterior arches of the spine, but the skin is intact. There's no exposed neural elements. Where spina bifida aperta, or an open neural tube defect, there's a defect in the posterior arches of the spine with exposure to neural elements and dysplastic meninges. It's associated with neurologic abnormalities. So spina bifida is one of the most common congenital anomalies of the CNS that's compatible with life. There are about 5.5 per 10,000 live births in the United States, and that's despite folic acid. And there are about 1,500 children born every year with spina bifida. So just background a little bit, going back to embryology. About the third week of post-fertilization, the neural folds join together and develop a neural tube. And the process starts in the midline and goes both caudad and cephalad, kind of like a zipping procedure, as you can kind of see. And the 25th day post-fertilization, the cephalad area closes. The 28th day post-fertilization, the caudad area closes. If it fails to close, cephalad, it can develop into anencephaly. If it fails to close on the caudad region, that's an open neural tube defect like spina bifida. And it's a very complex process. biochemically and biologically, and a defect in any of that process can result in an abnormality. So in general, when we talk about spina bifida aperta, or open defects, there are two types that we deal with. One is the meningomyelocele, and this is where there's a defect in the posterior elements of the spine with exposure of dysplastic meninges and neural elements. And these are just some images, some of the views from a fetoscopic view. You can see that there's kind of a defect in the spine with a big cystic area. The other defect that we see is myeloschisis, which is basically the same thing. There's exposure of neural elements without meninges, and so that's a defect also in the skin as well. So as far as risk factors for spina bifida, it's multifactorial. There's a lot of emphasis that's been placed on folate deficiency. There have been some very well internationally randomized controlled trials showing that folic acid supplement decreases the risk, but it doesn't eliminate it by any stretch. The other thing that we know that some of the anti-folic acid antagonists, some of the seizure medications like carbamazepine and valproic acid, put patients at higher risk for developing open neural tube defects. There also appears to be family aggregation. So if there's a family history of open neural tube defects, it also increases the risk. And finally, genetic abnormalities like trisomy 13, 18, triploidy are all associated with open neural tube defects. And then maternal obesity, poorly controlled pregestational diabetes can also be associated with open neural tube defects. They talk about a two-hit hypothesis. So the first hit is the development of the open neural tube defect, an abnormality that occurs in the first trimester. But the second hit is just kind of the toxic environment in utero. The neural elements that are exposed to amniotic fluid, it can cause other problems. And just to verify this, after they repair an open neural tube defect, it doesn't restore neural function. So there's something else that's going on in utero that causes it. Just a few images on prenatal diagnosis. These are some of the findings that we pick up on ultrasound. On the right, you can see a normal view of the posterior fossa and cerebellum. On the left side, there's the so-called banana sign. For some reason, we use fruits for just about every abnormality in maternal-fetal medicine. But the banana sign is Arnold-Chiari 2 malformation, where the cerebellar tonsils are pushed downward due to the open neural tube defect. The other finding that we sometimes see in the second trimester is the lemon sign, again another fruit, where you can see some frontal blossing along the forehead. And then just some of the ultrasound images, you can see the spinal defect on both the 3D and the 2D images. And finally, here's the top image is a view of meningomyelocele with a cystic structure, and on the lower side you can see a myeloschisis. So the standard of care up until recently is just expectant management when we diagnose an open neural tube defect, and newborns undergo neurosurgical closure in the first 72 hours of life, and the goal is to reconstruct the neural tube, protect the neural elements, and halt the CSF leak. Unfortunately, it doesn't restore neurologic function despite all their efforts. And the survival rate into adulthood in kids who have open neural tube defect is about 66 to 75%. And complications are common, including hydrocephalus that requires VP shunts, tethered cords, seizures, cognitive delays, bowel and bladder dysfunction, and sexual dysfunction. So when we first started looking at fetal surgery after years of doing it on animal studies, ethically, the only indication for surgical repair was in a life-threatening situation where it might justify to put mom at some potential risk. This is really a paradigm shift to move toward open neural tube defects, because most people, most newborns that have open neural tube defects can survive. So the whole idea was to halt some of the problems that they have from the two-hip hypothesis. The whole idea of doing open neural, fetal surgery was to halt the progressive impairment from the amniotic fluid and the exposure in the in utero environment. So the first cases of the open fetal surgery to repair open neural tube defects were probably in the late 90s and the early 2000s. And it would seem like a big deal. I think that just about every facility was trying to gain bragging rights and saying, hey, we need to do these fetal surgeries, we want to repair open neural tube defects. I think that there was enough sense to stop things and make sure that they were actually doing the right thing. And so the NICD came up with the MOMS trial, and this was a trial that involved Vanderbilt, the Children's Hospital of Philadelphia, and UCSF, and they had some really strict guidelines about who they would be candidates for repair. And so the results of this study were published in 2011. And the long and short of what they found, they ended up closing the study early because they found significant benefits in fetal surgery. They showed a significant decrease in the rate of shunt placement at 12 months of life, 40% versus 82%. And then if they followed them out for a couple of years, up to 30 months of life, they showed that there was a higher rate of independent ambulation if they underwent prenatal surgery as compared to the standard post-delivery management and repair. So following the MOMS trial, that started to become the standard of care. And again, real strict protocol in as far as who they offer the surgery to. The goal of the whole procedure is to operate on the fetus while maintaining placental perfusion and to continue gestation as long as possible postoperatively. Fetal surgery is a multidisciplinary effort. It's total chaos inside the operating room, or at least it would appear that from the outside. So there's OB anesthesia, maternal-fetal medicine, fetal cardiology, NICU, pediatric surgeons, pediatric neurosurgery, respiratory therapy, the operating support. It requires general anesthesia, and as you can imagine, a very high level of inhalational medications to keep the uterus quiescent during the procedure. Desflurane is kind of the preferred inhalational agent because it helps maintain maternal cardiac output without causing problems with the uterus. And they have to utilize some special devices, special stapling devices when they do the hysterotomy to do the repair. The problems with open fetal surgery, as you can imagine, usually patients are on 3 different types of tocolytics. They get magnesium, they're on indomethacin, and as well as procardia. So there's a higher risk for pulmonary edema, higher risk of placental abruption. So there's definitely some maternal postoperative complications. The other issue, you make a hysterotomy, so 100% of the patients that had the open procedure would have to be delivered by cesarean. And so there's a higher risk of uterine dehiscence, especially if they've underwent prenatal repair. And so about 9% of the patients when they went through the MOMS study had uterine dehiscence. And there's a high risk of maternal blood transfusion as well with dehiscence. Again, the big problem with the open surgery is 100% of them require cesarean delivery at 37 weeks. And the potential complications that go along with that, higher risk of placental accreta and hemorrhage and postpartum hysterectomy. This is a study that was published a few years ago talking about the requirement for cesarean delivery and the fact that we were creating some problems by doing this procedure. So the other thing is a higher risk of premature rupture of membranes and prematurity. Even the patients who were enrolled in the MOMS trial, there was an 80% risk of preterm delivery. The average length of gestation was about 34 weeks. About 13% of the deliveries occurred prior to 30 weeks, and a 46% risk of premature rupture of membranes. So clearly, even though we were doing some benefit to the newborn, there were some maternal risks that could have implications in future pregnancies. So during the time that there was a moratorium on open fetal surgery for spina bifida, in other countries, I think mostly in Brazil and Europe, there was a big push to move toward fetoscopic repair and new technologies that went along with that. And so I wanted to spend a little bit of time talking about that, which is the latest version of fetal surgery. So again, early attempts in the 1990s and 2000s, they had pretty unfavorable outcomes. When they had the moratorium on the MOMS trial, there were some improvements in fetoscopic techniques that made it a lot more beneficial. And the whole idea of doing it fetoscopically was patients wouldn't be obligated to have a C-section. It removes the risk of spontaneous uterine rupture. Again, you don't have to have such a high level of inhalational anesthetics, hence that lowers the risk of pulmonary edema and obviously a shorter hospital stay. So there are a couple different types of fetoscopic repair that have been developed. One is a percutaneous approach where everything is done through small incisions on the abdomen. Another option is to do a laparotomy assisted or open approach where a laparotomy is made. You can see that they placed a plastic sheath around the uterus after it's exteriorized, and that's how they do the fetoscopy. The benefit of doing it this way is if you have an anterior placenta, you can do a posterior approach and do the repair that way. And then there are also a couple hybrid approaches. There's a mini laparotomy approach, which is kind of a hybrid between the two different options. So the percutaneous fetoscopic technique, the uterus remains in the maternal abdomen, so it requires minimal doses of inhalational IV anesthetics. The closure of the uterine trocar defects and plication of the membranes is not possible. So if you do it percutaneously, it's hard to repair the uterus, especially if you have to put laparoscopic ports laterally where there's big vessels. Sometimes those areas remain open. The laparoscopic assisted fetal approach it requires a laparotomy, usually a fan and still incision. They use ultrasound guidance to identify where the ports are placed. And although it requires a little higher dose of inhalational anesthetics and tocolysis, it's a halfway point. And you can applicate the membranes, which probably lowers the risk of premature rupture of membranes when you have able to see the uterus itself. Finally, one of the hybrid procedures they use is percutaneous mini laparotomy. It pretty much does the same process through a smaller incision, so you don't have to exteriorize the entire uterus, but you do have direct access to the uterus. And so you can do a repair a lot easier and complicate the membranes. So it's kind of a halfway point between the two procedures. Just some images from a fetoscopic repair of meningomyelocele over the course of the procedure and then post-delivery. And then so there have been some recent studies comparing the open procedure to the fetoscopic repair, and the postnatal outcomes at 12 months were very similar to the MOMS trial. As you can see, there's still a high risk of premature rupture of membranes, but it's about equivalent to what it was in the MOMS trial. The gestational age of delivery, about the same. The big difference is that they're not obligated to having a cesarean section. Just a little more data that they found, at least on the initial outcomes, is the neurologic function is essentially equivalent to the mom's trial. So the short-term outcomes seem to be quite favorable compared to open repair. The verdict is still out on long-term outcomes as far as ambulation and bladder function, but things will progress. And so the big plus about the fetoscopic repair is it doesn't require cesarean delivery on every case. So I wanted to make a plug to my colleagues at the Fetal Center, the Grant Scott Bonham Fetal Center at the University of Utah. They are now starting to do open repairs of spina bifida here in Utah. Plans are to eventually move toward the fetoscopic approach. And they do a number of different needle procedures and some other issues with fetal surgery, including shunt procedures, open fetal surgery, exit procedure if there's a fetal compromise, where you use the placenta to support the baby in a difficult airway situation. The other thing that they're starting probably this fall is treatment for monochorionic twins, twin-twin transfusion trap sequence. And eventually, we'll move to fetoscopic repair of meningomyelocele. And I want to acknowledge my partner, Martha Monson, who is the co-director at the Grant Scott Bonham, who helped me with a lot of the slides and the images. She's a great addition and always willing to help. And she's been a great resource for us, especially in some of the difficult cases. And that's all that I have. Are there any questions?
What's the post-recovery for the mother? How long does she have to stay down, and can she resume normal activity after?
So with the open cases, they're usually in the hospital for 4 or 5 days. The fetoscopic repair, 2 or 3 days at the most. The open repair, they're still pretty sick, real high risk of preterm labor and premature rupture of membranes. So that one, is a little bit more involved, but the open cases are a lot quicker. Go ahead.
From a preventive perspective, I was wondering if you use folic acid or the activated folate with the 5-methyl group on there.
I mean, right now, what we usually use, especially if mom has a history of open spina bifida, we just use standard folic acid, and it's a higher dose. It's 4 milligrams up until 12 weeks gestation. And like I said, it has had a significant improvement, but it hasn't eliminated that risk. It's not quite as simple as just folic acid, so there still are frequent cases of open neural tube defects. It's a little bit more complicated than just folic acid. But yeah, we just use standard folic acid. Thank you.
I have a bunch of questions. Don't
Okay,
leave yet.
great.
I'm great to have you here. So is there any consideration when they go to surgery regarding the placenta implantation site and how that affects the surgery?
So it is interesting. They normally, when they do the procedure, they have to map out the placenta. That's, I think, the goal of having maternal-fetal medicine in the procedure. And they'll actually map out where the placenta is at and where they can put ports in. A lot more difficult if it's an anterior placenta, obviously. And that's part of the reason they have to, where they do either the laparotomy-assisted fetoscopic surgery, open surgery. They can do an incision on the posterior part of the uterus. They can do the hysterotomy there.
So they could work around any placental position. Good.
Most of the time.
Is there an optimal timing for the surgery? Gestational age?
So the mom's trial was 19 to 26 weeks gestation. And with all the new surgeries, they pretty much stuck with those protocols. So 19 to 26 weeks.
Great. I'm going to take advantage of one more question. I know everybody wants these questions, so I'm going to ask them. As we move to cell-free DNA technology and screening in prenatal care and away I don't know, at least in my practice, I'm moving away from multiple marker screening. Are we decreasing our ability to detect these defects?
It depends. Ultrasound is really good at picking up open neural tube defects, but it's only as good as physics allows it. If we have someone who's morbidly obese and we can't see the spine, it's not helping us a whole lot. They quote about a 95% detection rate for open neural tube defects if you can see the brain and the spine. So, like it or not, things have kind of moved in that direction. But I do agree. I still think it's important to screen for maternal serum alpha-fetoprotein because there's some outliers you're going to miss.
Okay.
And so I still think it's important.
Well, thank you very much for joining
Thanks.
us. You
Appreciate
bet.
it.
We'd love to have